Everyone to today's really exciting topic, which will be street medicine. And we're joined by Lindsay Fox, who is a physician's assistant here at in the Department of Internal Medicine. She serves as the founding partner and director for the Center for Inclusive Health, which is the operational home of the mobile medical teams at UNM, and they provide street medicine to unhoused and precariously housed folks in Albuquerque and Bernalillo County. This is a great opportunity to tell you a little bit about that before Lindsay starts. The Center for Inclusive Health recognizes that offering direct medical and psychiatric care to the patients on the streets was a significant and important role that the Health Sciences Center could offer. By going to the people, these teams provide acute medical care, initiate substance use treatment, and assess mental health and develop treatment plans for people who are there. This direct care delivery model can reduce emergency room visits, provide much needed follow-up for patients who are hospitalized due to trauma or severe illness, and begin life-saving treatments for people with severe mental health disorder and substance use disorder, which we definitely focus on here with the Southwest CTN. But I want to say that it's bigger than that. It addresses a lot of other chronic medical needs and disabilities that are very prevalent in this population. So in addition to providing to her work on the street, Lindsay participates in research and policy development around substance use disorders and mental health in unhoused populations. She works really closely with the Clinical Trials Network, our Southwest node, but nationally with the Circle program. And this is a program that has brought together community folks from all the different nodes across the country. So if you have a complaint, take it to Lindsay. Now, if you have something great or a great idea, you can always reach out to any of us, but we're really glad that Lindsay is a partner with us on CTN. So with that, unless there's anything else, I'll turn it over to Lindsay. Thank you.
Thanks, Dr. Page. It's wonderful to be here. I see so many familiar faces. Hey, Laura. This is really a community, and and really it's in communities that will care for people. It's not systems, it's communities. And so as we start this talk today, that's one of the topics that I want to resonate, is that we find our communities, we find the people who share the same values, and we take it to the folks who need it the most. And that is what has driven my work. I have this little funny background from UNM because I was so cold this morning. I don't know where majority of you are today, but New Mexico had spring for about a hot week, and it is freezing. And I was out on the streets this morning doing a pop-up clinic, and I was just reminded, just not only do folks deal with mental illness and substance use disorder, they are doing it in conditions that can vary and change. And I'm just really grateful that I was able to come home and have a cup of tea. So just one other quick thing. I'm really proud of the Southwest CTN. As Dr. Page mentioned, I sit on the Circle network, and it's a group of folks from every single one of the hub centers. And it's amazing what we do in our hub. You know, we don't really have a big city. Sure, we have smaller cities, but when you think about the Northeast, which has Boston and New York and all of the bedroom communities, and even down in the South with Miami, the creative thinking that we've used in this network has really set us up to be integral partners with folks who are doing things in much larger cities. And oftentimes I get an opportunity in the meeting to be like, yeah, we've been working on something like that. Let me show you some of our best practices. So know that your participation in this definitely resonates community-wide, but is also being recognized nationally. So thanks to this group for, digging deep and trying to come up with solutions. Let me share my screen. We'll get that going. Can everybody see that? All right, right on. Let's see here, I'm going to make it more presentation driven. So I'm going to make it sort of a street medicine 101. A lot of you have probably already been doing a lot of the concepts or embracing the concepts that drive street medicine. And this is just an opportunity for you to ask questions about what I do, and also hopefully provide an opportunity for me to learn what you're doing, if it's a best practice that I can incorporate into my work. So as Dr. Page mentioned, I'm a physician assistant in the Department of Internal Medicine, where the Center of Inclusive Health is housed, and this is at the University of New Mexico. This is a sand painting that some people experiencing homelessness did last summer, and those rocks are fascinating. They're aquarium rocks. So it just kind of reminds me that we all have amazing talents to bring to the table. So today we're going to just have 3 basic learning objectives. What is street medicine? Why is street medicine important to conversations about solutions to end homelessness? And what we're doing here in Albuquerque and what are the impacts? And I'm going to try to do my best to watch the chat, but I really, it helps me to learn or answer questions. So if you have a thought, just shout it on out there. So this is a really long definition of what street medicine is. And I grabbed this from the Centers for Medicaid and Medicare about how they view. And the reason I chose their definition is starting in October of 2023 and now in New Mexico, starting January 1st, our state is reimbursing for all visits on the street. And so I think what is important is that we recognize that the federal government has also come to terms with the fact that some of our healthcare systems are not set up to help those who need it the most. And by initiating this long, wordy definition, we've circumnavigated that. But what's really important is I want to bring some concepts. And what I want you to think about mostly are these words of delivered directly and unique needs and circumstances, and providing this care exactly where they are and on their own terms. I think that that is so important. I had to go to my primary care last week, and I will tell you that none of those were really met. And I understand we have to have conformity, but if you're struggling with substance use disorder, severe mental illness, or chronic disabilities, to have that empathy, to have a system that creates that empathy can really help get you on a better path. So people ask, what do I do on the street? And this is a little diagram. We do just about everything you can do in a clinic. So we see, I do a lot of primary care. I do hypertension, COVID, diagnosing and treating COPD, STIs, cellulitis, wound care, GERD, HIV, Hep C. We do it all. And I think I have a picture of my pickup truck in here, but we opted not to go with a big mobile unit to stay with the philosophies of street medicine. We operate out of a Ford Ranger, and you'll probably see the tailgate turns into a exam table. So just to give you all a brief history, I have to really identify and honor Dr. Jim Withers, who they consider to be the founder of street medicine. He was a hospitalist at Allegheny Health in Pittsburgh. And what he saw was the same folks coming back to his hospital, either through the emergency room or direct admit, with the same issue time and time again. And what frustrated him is that someone would come in with a COPD exacerbation, he would get them all buttoned up, back on their medications, unfortunately have to discharge them back to the same ecosystem that precipitated the visit. And he saw this over and over again, and he started to feel absolutely hopeless. And so what he did is he decided to go back into that ecosystem and follow that patient. And what he saw really changed his mind and helped create this practice of street medicine. In 2005, he gathered with Dr. Jim O'Connell, who had been doing the same work at Boston Healthcare, to have a symposium where they could gather and share best practices, look at different skill sets, and start advocating for policy change. And then in 2009, Dr. Withers and other like-minded folks from around the nation, actually around the world, founded the Street Medicine Institute. And this is dedicated to promoting the mission of street medicine, focusing on policy. And it's really a phenomenal gathering to learn about what is happening, not only in medicine, but in social justice regarding people experiencing homelessness. Dr. Withers came up with the statement of go to the people. And Dr. Page used that in the beginning, and that's really what drives the work we do at Center for Inclusive Health. These are some of the goals. And I think for many of us that are on this call, we share those: patient-centered, culturally sensitive. We work with the patient in the context of his or her unique reality. My reality as a employee of UNM is much different than maybe a 30-year-old woman who is living in Albuquerque on the streets, struggling between housing, struggling between partners, struggling between food and medications. So it's important we recognize those. And really, again, what drives us, our North Star, is this model that emphasizes compassion, collaboration, equity, creativity. Sometimes there's a lot of stuff that I'm making up, like how do we change this and really work with the folks? So, why should we care about this? And I get that a lot. I get that a lot when I'm talking to public figures, when I'm talking to government relations. Why should folks care about that? And I have to remember that when you're in the trenches, it seems obvious. But one of the things I think about is in 2022, we had one of the highest counts of people experiencing homelessness in the United Nations, and one of the highest counts of people identified as chronically unhoused. And what I want to say with all of this data is a lot of this data is the best that we could have, but we're realizing that there were gaping holes. And one of the best parts of my job has been working with Dr. Page's group at the university to really look at root causes of homelessness in New Mexico. Because as we see, we were really lacking in accurate data. And I think we could be drastically undercounting these numbers by a third. We saw upticks in racial, ethnic, and gender subgroups. And what we also saw is at the same time as people experiencing homelessness was growing, the services were contracting, falling short. But one thing that came out of COVID was that we actually experimented with some policies that we know now can keep people in housing. And there were 4 areas. And one, we enacted the eviction moratoria on a federal level, and then emergency rental assistance. And then we made additional investments into homeless assistance and housing vouchers in terms of motels, in terms of pop-up shelters. And what we know and what this showed us is that despite the growing number, we actually possess the skill and at that time, the political will to put the brakes. Unfortunately, a lot of these actions have been rolled back. And we're seeing higher numbers in our community. But this group, and I'm sure most folks on the call and that you work with, we know that the data, and this is from Tufts 2021, that when you look at housed versus unhoused, the disparity in health outcomes is drastic and striking. And so we know that if, 84% of the unhoused population has physical health conditions, osteoarthritis, cirrhosis, COPD, hypertension. We know that their mental health conditions are significantly worse. And one of the things I've been looking at data is that did they have those conditions before they were unhoused, or did they develop those conditions by being unhoused? And that's a question that I constantly toggle back and forth. And so if anybody has, I have my own sort of gross data by doing the work on the streets, but I think that that's something important to think about. And then we also know that substance use disorder, again, is higher in the unhoused than the housed, but I'm not sure that that disparity really is as clear as it could be. I actually think there's more substance use disorder in housed folks. But again, we need to make sure. I've met a lot of people who did not use substances until they were unhoused. So that act of becoming unhoused actually dropped them into the substance use disorder. And then finally, the last column is this trimorbidity, where people that are experiencing homelessness, quite frankly, experience all three at the same time at a much greater rate. We know that homeless individuals face a 3.5 times mortality rate. So just being homeless ups your risk of death. It is, again, one of the root causes of poor health, and the average unhoused person dies 20 to 30 years earlier than housed people. So we know to prevent dying that housing works, and housing should be medicine. And that's something that we're thinking about on the policy level, experiencing and having conversations with Medicaid providers here in the state about doing some studies around, hey, let's house these folks and let's see if we can improve their overall outcome just with a 90-day stay while we try to get them on SSI or apply for housing. Again, schizophrenia, depression, much higher in unhoused. And then I left substance use disorder because I think our data is still pretty weak. And as we start focusing on better ways to incorporate people experiencing homelessness into our data collection and survey, we'll have a clearer understanding of the true levels of substance use disorder and triggers for that. But again, the highest levels of healthcare, health conditions that I'm seeing are hypertension and coronary artery disease, oftentimes resulting in a stroke. Diabetes, Hep C, HIV, sexually transmitted diseases are on the rise, both in unhoused folks, but also unhoused pregnant women, and COPD. We're also seeing an explosion of congestive heart failure due to methamphetamine use disorder. But one of the things I think about is it's great to talk about Boston. It's great to use data from the Bay Area, but let's talk about New Mexico. And this is an interesting chart. And mainly, you know, the one thing that I like about it, or that I want to focus on because of our time, is really looking at the data point in 2022 and the absolute straight line, almost straight line, that goes up to what we estimate the PIC count was in 2023. And I suspect we will see that same upward trend when we get our reports back from the point in time count in 2024. For those of you that may not know, every year the New Mexico Coalition, they go out on the street with volunteers and try to collect data on folks experiencing homelessness and asking salient questions. And basically what it does is it just gives us an idea of the people experiencing homelessness in the metro area. I think it is a noble effort. I've participated the last 3 years. I think the survey is getting better. But I think we have some work to do, and I think it's also drastically undercounted. But, you know, when we saw that increase after 2022, as the moratoriums started to come off, as we started to kind of the world started opening back up, we saw a 50% increase, and it's multifactorial. I think one of the things that we can look at is that rents in New Mexico increased astronomically while income of New Mexicans stayed the same or dropped. Now, during COVID, when people were getting money, we were able to see that stabilization. But once those came off and the expectation were for people to return back to jobs that didn't match the level of housing, we saw a huge increase in poverty, which leads to people inability paying rent, which leads to homelessness. We also have 1 in 5 with severe mental health issues that make it difficult for full-time work. 1 in 10 suffers severe physical health issues, also making it difficult. And unfortunately, when you compound that with us just statistically being number 1 and number 2, number 1 in alcohol deaths and number 2 in overdose deaths, you get this perfect storm of how hard it is for folks to stay housed when the system is almost engineered against them. I know that my own kids, while they're at college, their rents went through the roof in areas, God love them, that really you kind of wonder, how does someone charge $1,300 a month for an area that that is a food desert, that doesn't have good walkability, that there's no transportation to get to my job or to, you know, their jobs. My kids have by being my kids, they have access to vehicles, but if you were having to walk or you were having to get your kids to school, it would be virtually impossible. So as a result, one of the things I've been thinking a lot about, and those of us at the Center of Inclusive Health with our work on the street and being able to participate with Dr. Page and her team, is that we truly believe this current state of people experiencing homelessness can be resolved and we can address it. But what it's going to take is all of us harnessing together political will and resources and skills, everyone coming to the table with their skills, but also recognizing their blind spots so we can ease the suffering and really move towards ending homelessness and slow down that trajectory that I showed you on the point in time count. And when we looked back at that data regarding the incredible health burden, both physical, mental, and substance use burden that these folks experience, street medicine has to be a part of that, because the typical healthcare system may not address or serve those most acute and most likely to die on our street. And so for us to have solutions that are grounded in empathy and health equity and solidarity, street medicine is there to provide that bridge so that we can get folks on their path towards well-being. So the Center for Inclusive Health is at UNM. I think I'm the director de facto. I didn't come up with this idea, but I decided this is what we should do. And Dr. Alicia Parada was very supportive and agreed to house it in Department of Internal Medicine. And then I was able to coerce, but she's an amazing provider. If any of you know her, Dr. Sarah Dorley, who's board certified in addiction and internal medicine, she came over and she's now our medical director. So she brings a wealth of experience in her residencies and her fellowships that were in the Bay Area serving marginalized and underserved populations. I'm extraordinarily happy to have her and very lucky to learn from her. We are now finishing up hiring 2 CHWs and medical assistants that will be joining our team, hopefully by the beginning of April. And so we'll have 2 teams out on the streets of Albuquerque providing pretty much full coverage 5 days a week. We may switch that up and add some weekends, but we're really trying to tell the streets are trying to tell us what kind of program we need to build. As I said, we're out on the streets right now 3 days a week. We have 1 vehicle, a truck, that's been really, really helpful in providing an access point. Currently, we have a psychiatrist that goes out with us on Fridays, and they really lean in and provide diagnosis and treatment plans for some of the most acute psychiatric patients that refuse to go to the psychiatric emergency services or that are not eligible for ACT teams. So that's been very, very helpful to help complement the work of internal medicine. Both Dr. Dorley and I prescribe Suboxone, and we've been doing Suboxone inductions on the streets. We also provide chronic illness care, COPD, hepatitis C, HIV. As we were talking earlier, we've really developed some great relationships across the city with pharmacies as well as labs, since we don't draw labs on the truck, to help us get the care that folks need. In addition to that, we've teamed up with Albuquerque Community Safety, who also has a response that's driven by calls to the city, and AFR and APD. So we're able to go out and make connections with folks to get social services, shelter information, other types of housing. We do housing assessments. We initiate the beginnings of a SOAR application. For those of you who may not know what that is, that's to be eligible for Social Security disability. We have a veterinarian that comes out with our team 1 day a week. So many folks have pets, and these pets need care and food as well. So that's been really important. And then we also help folks get connected with IDs, Social Security, and SNAP benefits or general assistance. A lot of these services folks aren't aware of, and so they really need someone to walk alongside them. So there's a little picture. You can see the flatbed or the tailgate of my truck. I'm doing some wound care. It works really, really well to be able to do that. I'm pretty self-contained. There's Dr. Dorley. We're in the Southeast. One of the things we saw a lot this winter were a lot of burns due to fires. You can kind of see the detritus from burned out fires and a woman who just could not walk. This is a gentleman, that encountered us in one of our walk-up clinics. He had been a victim of a stabbing and left the hospital AMA. And I was able to kind of get his name and his, date of birth. And I was able to coordinate with my pals on the trauma unit, and we're able to get him the care that he needs. And that led to a new partnership that we have with the UNM trauma team, is that we now do inpatient consults with appropriate trauma patients to help the trauma team and the case management at UNM provide a better discharge to reduce rehospitalizations. And then we go and follow these folks either in the shelter, or if they leave the shelter, we have points across the city where they can catch up with us, and we can take care of their wounds and make sure they're not infected. Again, a lot of folks on the street have difficulty making appointments at 2:30 or 2:20 at UNM. Especially if they're carrying all their belongings. It's just too difficult. So we're trying to figure out a bridge there. There's Dr. Dorley and myself in our Ford truck. Again, another trauma individual. This individual is flown in from Shiprock, who left AMA, and very, very sick individual that we were able to coordinate with our partners at UNM to get him through the emergency room. And I believe from that moment, he was in the OR within an hour and 30 minutes for severe wound care. And then this is one of my favorite patients. I always pay homage to her in any lecture. Her name is Baby Girl Perkins. And Baby Girl Perkins probably taught me more than anything about street medicine. So as I go forward, I always keep her as my shining star. Unfortunately, we lost Baby Girl last year to just a devastating cancer that went largely undiagnosed. And, it's really a shame that had to happen. It didn't need to happen. But what was fortuitous is I was able to be with Baby Girl, and Baby Girl passed away in her own home. She'd been unhoused for 20 years, but she was able to regain her family and see her children. There's some outcomes we can't change, but we can certainly help folks move towards health and well-being. All right, let's see here. Next slide. There we go. So we're doing this care in encampments by walking along Central and some of the more highly trafficked areas, and in transitional housings. We're doing pop-ups. So every Tuesday we go to a different quadrant of the city, and we set up with ACS. APD is in the background because some of those areas that we're in are just not the safest areas. We were at a place last week where there was the largest number of calls for APD in 2023, but that's where the people are. And so we're there providing care. And what's really important is that ability to say, we see you, we hear you, we're coming to you in your neighborhoods. And that keeps the power with the patient. That allows us to work with them as opposed to asking them to come into our world, which at times has not served them and at times is structurally violent. This opportunity to sit with folks in their world and really see them and hear them might be one of the strongest tools in medicine I've ever possessed. We focus a lot on folks with high acuity and high utilizations, and we try to serve those most likely to die on our streets, those that cannot access the typical medical systems. That was a big encampment under Broadway and First. I like to take a lot of pictures because it really tells me what's going on, and it helps me remember why I'm in this work. And any patient that you see has given me permission. There's a lot of really interesting graffiti, and there's a lot of interesting poetry on the streets, and it really opens my eyes to how folks see the world, and that helps me be a better provider and meet them where they are. I'm in transitional housing caring for a guy. There's Dr. Dorley and I at Tramway in Central. This is a woman, and I hate to tell you these stories, but I think it highlights. Her tag says Joe Doe. She went to one of our local hospitals, not UNMH. She had had a stroke, but no one could communicate with her. They didn't try, I don't know what happened, but they just named her Joe, and they called her Joe Doe and sent her on her way. And we found her walking down San Pedro. And what was so interesting is Dr. Dorley is fluent in Spanish. And was talking to another patient and she heard Dr. Dorley and came over to Dr. Dorley and said, you know, I speak Spanish and no one asked me. And so I couldn't understand them, but I also had a stroke. And Dr. Dorley was then able to suss out through her stroke impediment what this person needed. And we've been able to get her housed and connected with care. So just to remind folks that everyone has a name and it's really important to learn it and try to figure it out. Another encampment along I-40 was a sign I saw that kind of broke my heart. And then this was one of the largest encampments that we worked last year. And at that encampment, we were able to get almost 75 people into transitional housing and another 35 onto permanent vouchers. Christina, how are we doing on time?
We're doing pretty well. I think we probably want to leave about 20 minutes. So I would say about 7 more minutes.
Okay. Thank you. And again, if anybody has any questions, but this is my last pitch. And this is honoring one of my dear mentors, Dr. Brett Feldman, who's a PA at USC and the program director there. And he really wants all of us to think about radical humility for reality-based healthcare. And you kind of say to yourself, what is that? And I always use this picture. It's a house on fire. And we know that firemen run into the burning building and take the patients and bring them out to safety and to treatment. And what I often say is in street medicine, we do the same thing, except ours is not necessarily a fire, it's the streets. And so the skills that we use to help folks experiencing homelessness are very similar. We go into the fire, we go into the streets to bring them out to the resources because they just can't get there. And it's interesting because when you're in a house, a burning house, we don't expect you to try to figure out how to get your way out. We actually send people in to lead you out. And I wonder a lot why our same thinking hasn't thought or doesn't follow the same line of with people experiencing homelessness. We're very like, you got yourself into this mess. Here are the resources. You have to get to them. And I say, oftentimes we have to go in and help them. But often we have two choices in life when we're dealing with people experiencing homelessness, or I would say almost most things, most uncomfortable situations. And for folks experiencing homelessness and those of us that treat them, we have two choices. And the first choice is to look away. You know, a lot of people feel if they relate to unhoused folks that you might be more susceptible to their suffering. And none of us really want to lead into that suffering. Or we take part in the othering where we create them. Well, they're not like us because they're drug addicts. They're not like us because of poor financial choices. I mean, we can come up with a whole dialogue about that, but that concept of othering. And what I would postulate is when we look away and don't relate and actually choose based in fear to create some metaphor of why people are experiencing homelessness, we are creating spiritual poverty. We're creating spiritual poverty for ourselves, but also for those folks on the street. And while many people that we treat have material poverty, financial poverty, I think the one that really grinds people down the most is this concept of spiritual poverty, which is trying to live in a world that doesn't want to see you, doesn't want to bother with you, doesn't want to care for you. I would also go on to say that it not only hurts that person, but it hurts the rest of us. And so we're all suffering. These behaviors lead to sort of community suffering and moral injury. And what Brett postulates, and I've chosen to embrace, is this idea of radical humility, where we choose to engage and remain humble and remain proximate, meaning leaning in, learning folks' names. You can see Sarah and I always try to take a position beneath the patient to continually to keep this person who has experienced living in a world delivering them spiritual poverty, the opportunity to stand fully in their power. And we're here to serve. And when you do that, you share in the suffering of others and you can choose empathy. And I would postulate that that actually leads to reduced suffering for all of us. And we see that in studies looking at moral injury. When you can actually lean in and serve, you come away with a sense of gratitude and humility. I often say too, street medicine is the cure for burnout. So if any of you in the system are experiencing burnout, I can certainly relate, but I found that street medicine has been a salve for that. And finally, you know, I challenge all of us to think about that fireman's concept. Sympathy is, well, I'm really sorry you're down here, but I'm up here with all of these resources. And if you can get yourself out of the hole, I'm happy to help you. And empathy is getting into the hole and saying it's dark in here and how is it going and how together are we going to get up to the top so that you can access all of these services that as a human being you're entitled to. And empathy is where we're based and where we try to stay grounded at the Center for Inclusive Health, Mobile Medicine. These are our 5 areas. We have the medical team, education, research, community collaboration, and policy. And I like to always finish my lectures with a couple of books or podcasts. If anybody has read any of these, I think these are amazing books that have helped me continue to do the work and open my eyes to blind spots. And the podcast, Ezra Klein with Jerusalem Densis is pretty amazing looking at the data. There's that. And so thank you. I appreciate your time and would love any questions. My email is there. So if you have any feedback or thoughts or comments, I'd love to hear from you.
That's a
Mr.
lot of loud clapping.
Thank you.
We can see it all over the screen. Yeah.
Thank you. Julian, I'm glad you have a question.
A little bit of a question, kind of also some, I don't know if you're aware of this kind of work that's been going on in the community too. So my day job, I'm a therapist with Duke's Recovery Toolbox. I'm a social worker primarily.
Okay.
Outside of my work, I work with an organization called Black Cross Street Medic Collective. And we actually do some homeless, very basic level medical care to the unsheltered community as well like, because like when we talk about like street medicine, something that we also learned here in Albuquerque was like street medicine is the medical side of it too, but it's also like the protest support stuff, and that's where the street medics also, that's where like me and other community organizers come in and like we'll help provide street support for protests and other events that are going on. Because like that's also a fairly critical need too. You have like large groups of people. And we when we're not doing protest work, we're also helping out the community as well. We have resources. We will do basic wound care, we will do basic referrals. I mean, some of us have like advanced medical training, some of us are therapists, some of us are volunteers that don't really have any sort of but it's a full community effort, and we constantly are seeing the need for adequate medical care within the unsheltered community. Because y'all are just 2 people, and it's a huge process. So
Thank you for that. And thank you for, you know, really expanding what street medicine means when you're going to the people. And I think it's important that all of us join in whatever capacity we can bring. You know, you said you worked at Duke City Toolbox. Yeah, Dr. Duhigg actually taught me a lot. I worked with him in the past. And so as we go through this life, we pick up tricks from all of our mentors, right? And so I think the more that we can just care for one another and learn what each other are doing, we're going to create that city of empathy that I know we can be, because I've seen it in the work that we are bringing nationally. You know, I always say, if you can do it in New Mexico, you can do it anywhere, because we're usually understaffed, really poor, and very rural. So if we can do it, Philadelphia can do it. So thank you for highlighting those efforts.
and there are
Lindsay, I want to say thank you so much. That was so great. I'm sorry, Julie, I'm just going to cut you off here for a minute. I want to put Christina in charge of moderating so that Lindsay doesn't have to try to juggle multiple tasks of Zooming and clicking. So we've got some other questions. Do you feel like you're done, Julian?
Yeah, no, I was going to shout out, there are some other community events that are publicized that offer harm reduction services, as well as like other like hygiene support services, bike repair, that are
Thank you.
honored in the community, and that
That's
right.
great. Okay, Christina, would you moderate, please?
Yeah, I'm gonna jump back and forth between the chat and the folks who raised their hands. I did get a message in the chat to me, but I want to share this with Lindsay. I think you can answer is, have you connected with the street medicine team in Shiprock?
We have. That's a great question. And I forgot to give you one of the most important things is that we currently at the UNM, we have a street medicine echo that we've teamed up with the leadership of the Street Medicine Institute and Asha Atwell, who is the provider on street medicine team there. She is one of our co-hosts and partners. And as far as I know, she's one of the only individuals in the United States doing exclusive street medicine care with Indigenous folks. And so she brings this incredible wealth and humility with her team every time they present. And so, Christina, I'll get you that information to send out to this group about how they can join the Street Medicine Echo. For those of you not familiar, we always have a didactic, which lasts about 20-25 minutes. And then we have a case presentation. And on that call is usually Dr. Withers, Brett Feldman, his wife, who's also a leader in wound care. And then most recently, we've added the director of street medicine from Ireland, who brings a whole host of experiences because their substance use disorder issues look very different than ours, and being in socialized medicine really creates a whole different environment. So I'll make sure you guys get that link if you're interested.
Wonderful, thank you. Yeah, we'll be sending out the slides and that information after this presentation. Shara Thorpe, you have your hand raised if you want to go ahead.
I had a question about, you had mentioned how you're using the Ford Ranger for the truck to treat people. Do you see any benefits of using, just a pickup truck as opposed to like a van or an RV? And what have you seen be the benefits to this? And by the way, I'm the opioid settlement coordinator. I am here representing Southern New Mexico, Doña Ana. So we are looking at ways on how to spend opioid settlement funds and working with our advisory. And so I thought this is a really good idea. And I'm looking into maybe doing something like this down south. And so I wanted to kind of get your feedback around the truck versus something else.
Great question. Again, if you've seen one street medicine program, you've seen one street medicine program. I let the streets tell us what we need, but also the dollars. And I had a very generous donor who said, I'll buy you whatever vehicle you want. And at that point, I chose a Ford Ranger, and the way that I have it outfitted is I have that bed, and then the thing, and then I have all these storage units, and then I have outside compartments, and it works super well. Again, with street medicine, it's about seeing people in their environment. I know a couple of teams have gone out and bought, and they're so fortunate to get the funding for these huge $750,000 vans that are fully equipped, but those take 2 to 3 years, and people are dying right now. And so my philosophy has been, let's just go to the people. Let's just make it work. And so the Ranger has been really helpful. I'm not waiting. And I get a lot done on the street with a couple of lawn chairs. I'll tell you what. So keep it simple. The other thing, and I had one guy say to me, he goes, I really appreciate you. Well, not, when we can roll out in $1 million vehicle, but we can't necessarily give you all the supplies for wound care. And so again, it's that perception. Please email me. You're welcome to come out. We just bought our second vehicle. We actually did one of those little Ford Transit vans, and I'm getting a unit built to put in the back. And so we're just going to the people. Let's just go treat folks.
Love that.
We'll take it from there. Yeah.
Wonderful. There's another question in the chat that says, as a non-clinician, what are some opportunities to get involved with street medicine in Albuquerque?
That is fantastic. And there's a couple of opportunities. We're doing these pop-up clinics, and if anybody is interested in supplies or contact me, like hygiene bags, so often folks just need wipies. I know that sounds seriously, but I don't know if you've been camping for a couple days, you just want to wipe your face, right? There's dignity in that. So we call them dignity bags, right? So brush your teeth, wipe your face, have some Gatorade mix, Those are really, really helpful. As we expand, we will try to find more roles. I believe all of us want to help, and I think all of us has something to contribute. And so we're trying to be innovative and creative about bringing everyone to the table, because it's only going to be when all of us get together and working towards what our passions are, our values are, and rooted in humanity, that we stand a chance. And so, yeah, it'll be, Christina, thank you for reminding me we're going to send these out. What I'll do before I send it to you is I will pop in the QR code for folks to click on to go to the Echo link. So that will be embedded at the last slide when you get them.
Great. Thank you. All right. I think I'm caught up on the questions and the slides. We'd like to welcome other questions. We have about 12 minutes left, and it sounds like a lot of enthusiasm in this group. What other expertise? A lot of expertise in this group. Other thoughts that come to your mind that you'd like to share with Lindsay?
So good morning, good afternoon, Lindsay. This is Noreen Kelly, and we're in Gallup at the Hojo Center, which is a drop-in center, and a lot of things going on here. But this is very interesting, and I know that you have to have a medical person, scriber on the team if you, but aside from that, to get the service going here, I heard someone mention the opioid settlement. What are the criteria for applying for that settlement? Anybody?
I don't know that. I mean, and Sharon may be able to give you that. I do know that Gallup is looking really, the IHS group in Gallup, I've been coordinating with them. I think I saw a provider on one of the, I think she's here today. So we're trying to help them, or we're all working together and brainstorming to get that service out there. And so as far as funding, we're not necessarily looking at opioid response funds, but whatever we can do to help and provide consults. We were fortunate enough to bring out the Street Medicine Institute, and they spent 6 months with us helping us build our program. I got a private donor to donate the money to bring them out here. And so I feel like I have all this wisdom or not. I have ideas and notebooks, and I'm willing to share them with anybody. So, doesn't do us any good if I just sit on them. So if I can help you in any way, let me know.
All right, thank you.
I see some questions that different parts of the state. And I don't know if Dr. Page, you have time to talk about it, but I know that Dr. Page did a bunch of research, her team, all across New Mexico. And those partners really were fundamental in giving us feedback about what's going on in their communities. And so ultimately, however I and Mobile Center for Inclusive Health can help brainstorm to help build a program that fits your community, we're here. And that's part of our mission, because when New Mexico, when we help everybody, we all do better.
Lindsay, I'm so glad you brought that up, because I didn't know if I should or not. We did just complete a survey of over 500 people who are experiencing homelessness in 10 counties in the state of New Mexico. And we're in the process of organizing all of the data, and then making sure that our partners get their data. And then I'd be happy to come back into this venue and share with everyone what we learned. And maybe we can get some, because they're the ones that wanted this data in order to help build programs. And so we're happy to make sure that you get to be a part of that dialogue, even if it's only through the Southwest node. But my first responsibility is to get back to the folks, the community-based organizations and the people, the social service folks who helped us, and make sure that they know we're not going to give that. We're not going to surprise anyone with data releases before the folks who helped get that So I'd be happy to come back here maybe in a month or so and present that. And Lindsay, if you can attend and others, learning how that goes around, how things work. Phil Feudy reminded me, we did a survey, I do the research part, Lindsay's a provider, but we did a survey some years ago and worked with a lot of folks who had hepatitis C in Rio Arriba. And it was people who were housed were more likely to have hepatitis C than people who were unhoused. And there are important sort of cultural and social reasons for that, but it's unlike anywhere else where mostly unhoused people have higher rates of some diseases, but we definitely see that there's also a lot of risk in our homebound populations. So, and they're very difficult to reach and see. So that's a really interesting observation that you've had, that actually data shows that that is true in some cases.
There's another question that popped up in the chat. This says, you mentioned having multiple sort of check-in centers and ways for folks to remain in touch with you because making it to appointments can be so hard. Can you speak a bit about what that looks like?
Yeah. So, one of the things we think about, and the data out there's a great study on linear time for folks experiencing homelessness. When you sort of leave our world and our concept of 1:15, 5 o'clock, 5:30, and you are now living on the streets for a more circular time, and you're really focusing on those fundamental characteristics of survival, your concept of time changes. And so that expectation that you can be in an appointment at 1:10 for 10 minutes to get your psych meds is really difficult for people. It's also difficult if you live in our state, which we have virtually no public transportation, or you must drive incredibly long miles, and there may not even be a provider in your neighborhood. So what we do is that we set up in different parts of the city on Tuesday mornings, and people know that's where we're going to be. And so we try to create space there. And then we also have a mobile phone that we give our number out to, and our team members take turns checking it. So if people do have a phone, they can call us, and it gets us an opportunity to get back in touch with them. And then we also have a lot of partners. I know where a lot of people just hang out in Albuquerque. I know that I can find people behind the alley at Circle K on San Pedro and Central, and I just know where they go. So there's lots of different ways to connect with people. Additionally, every other Tuesday, I have a brick and mortar clinic where I bring folks who are, there's almost everything I can do on the street. I haven't figured how to do a pap smear with dignity. So for women, I bring them into my brick and mortar clinic. And what that is it's a drop-in clinic. So if you show up between 12:30 and 4, you might have to wait a little bit, but we have folks with services helping you get connected, but you will be seen. And so you don't have to try to get there by 2. And if you show up at 2:10, you're not going to be turned away. You're going to be given a cup of tea and maybe a muffin, and you're going to chill and learn a little bit about, UNM Cares, which is our benefit center. So that's kind of how we make it work. If folks have other concepts of how they're doing it, please let me know. But it's about breaking down those barriers.
I'm not seeing any other questions in the chat. Does anyone else want to ask a question or share some thoughts or experiences?
I just wondered if you have a need for feminine hygiene for your dignity beds.
100%. We do. And I would take it even a step further, that there are some things that people identifying as female might like to have that we might, typical people, oh, that's just an extra. But there's certain things that we all like and that make us feel good in times of stress. And so we really are looking forward to trying to find bags that not only are hygiene, but we call them dignity, because there may be something there that brings you whatever small amount of joy and that you know someone took the time to care to provide for you. So absolutely, you know, one of our questions that we ask folks is, where are you using the bathroom? And for a lot of women, it's out on the streets. And so to be able to provide them with wipes or something really tries to restore their dignity in an area and in an opportunity. And so we're trying to work with the city to offer better bathroom services, safe bathroom services. So, because sometimes bathrooms can be places for assault or robberies or whatever.
Lindsay, everyone here wants to thank you so much. This was a really, really wonderful presentation. I want to thank everyone who attended. We really appreciate it. We want to hear your voice and your feedback, and we will look forward to seeing you at our next event. Lindsay, I would say in all my years doing research with folks who are underserved, this street, people experiencing houselessness is been on for decades and decades. So we're not going to solve it overnight, but when I see this kind of interest and commitment, and I think, you know, there's some hope here for us. So thank you all. Great presentation.